pleasure to be with you this afternoon. My name is Nancy Hanright, and I am the Senior Director of Real Estate and Space Planning at Boston Medical Center. I'd like to just give you a few brief facts about BMC. We are a 514-bed academic medical center located in the south end of Boston and the primary teaching affiliate for BU School of Medicine. We are also the largest safety net hospital in New England. In addition to that, we're the largest provider by volume of trauma and emergency services in New England as well. For those that don't know what a safety net hospital is, we are the largest provider of healthcare services for the underserved and underprivileged. About 70% of our clients or our patients fall under that category. When I first came to BMC, I was tasked with space utilization in the hopes that we could shed real estate. Healthcare reform was in its infancy, and we were not doing well as an institution. We were almost at the brink of receivership. And so I had the distinct pleasure of going through almost every single room at the hospital to figure out where we had gaps in space. One of the other things that afforded me was the opportunity to actually learn about other ways that BMC were bridging gaps. They had amazing programs, some of them first in the country. We were the first hospital to actually have a prescription-based food pantry, and we were also the first hospital that we are aware of, so if it's different, let me know, but to have a rooftop farm where we actually take the food that we grow and provide that to our patients, either on their inpatient plates or at the food pantry itself. So I'm here today to talk to you about behavioral health. And I am actually, as I said, a space planner really at heart. In 2019, the president of our hospital had selected myself and the operations manager for our primary care facility to participate in a fellowship program in Washington, D.C. for the America's Essential Hospitals. I sat next to this woman who I barely knew and tried to figure out how we were going to come up with a project that we could both be successful in. So after talking through different issues and options, we chose to talk about behavioral health. And her priority was integrating it into our primary care system, because BMC was a 3 million square foot campus. Our campus is 3 million square feet, and it's in Boston, old buildings, multiple on this campus, and we were losing patients that were referred both ways, actually, either from behavioral health to primary care or the other way around. And so we had several meetings. We created this great project that we were going to present. As I said, it was in 2019. The fellowship ended in 2020, March of 2020, to be exact. And so, as I was sitting in Washington, D.C., my plane arrived, and I was scrolling through my phone, having a nice glass of wine, when I saw there was a moratorium on travel, and I was in Washington, D.C., because of COVID. And so we quickly had to pivot our focus at that time. We did stay in D.C., but behavioral health did not necessarily end up being the topic of discussion. So we deal with COVID for a year. There's an institution in Boston called the Mass Hospital Health and Hospital Association, which there are about 70 member hospitals, and they took notice to the fact that our emergency rooms were overloaded. BMC was actually the first hospital in Boston to actually have to divert patients because of COVID and capacity. So the MHA started to track this data, and it showed that on any given day, we had between 500 and 700 patients waiting for inpatient beds in the state. Our own members, as I said, were underserved and underprivileged, were a high percentage of those patients. Our ED went over capacity by 53% as it relates to boarding. And we knew we had to take matters into our own hands because our emergency room is the front end of the hospital. And this backed up services, not for those that just had behavioral health issues, but any medical issues. So we went looking for real estate. I failed to mention earlier that we're also part of Boston Accountable Care Organization, and so we also have a health plan that provides insurance for health for patients. And because of that, I say our name is a little bit of a misnomer because we actually do treat patients from one end of the state to the other. Through partnerships, we also have 13 community health centers as well as partnerships with 3 other hospitals. And so it gave us the ability to capture a lot of data. And with that data, we focused on the great city of Brockton, which is about 25 miles south of Boston, because we knew that if we built this facility, the need was there. We had looked around for space and found this not so beautiful old nursing home built in the 1970s. As you can see with all the accoutrements of all of the things that a 1970s nursing home would have. No central AC, gas-fired boilers. I was like, this is gonna be really fun. And we were also challenged by the state because of their need for beds to get this up to speed quickly. And there was a $12 million incentive for us to do that. And so we took that challenge on. We built an 82-bed facility. 56 beds were inpatient psychiatric beds. 28 of them were what we call clinical stabilization services, which is a gap service. These are not people that are detoxing. They've detoxed, but they have clinical issues and need more time getting clinical care. And we also wanted to conceptually look at the building as an extension of our campus. And the other thing about BMC is it's actually known as the greenest hospital in the city. We have, I think Sarah had mentioned earlier, Practice Green Health. We've won several awards from them. And so sustainability is something that we think through and talk about all the time. We wanted to not just create a building where patients were healthy, but we wanted to create a healthy building. As part of that process, we built, we used a geothermal system in order to create our heating and cooling. We have also installed or getting ready to install solar panels in that building as well. The overall program, which I will not go through because that would be painful, but I wanted to show this rendering because it shows you the unique shape of the building. And so it's 3 floors. We had some future fit-out space on the bottom floor. We just didn't think we would have the funding to fill that up. As I mentioned, we had clinical stabilization services and the inpatient beds on the 2nd and 3rd floors. The unique shape allowed us the ability to actually build this courtyard that was in the middle. Access to natural light, fresh air, and views of nature have been proven to improve overall health and well-being, and we wanted our patients to have that. So I'm going to show just some renderings and talk through design strategies. You know, we paid a lot of money for them, so I figured we would put them in front of people. We use natural light as a way to bring in nature-based design, used biophilic elements, and took the time to make sure that our materials were selected to avoid vinyls, VOCs, and other chemicals and other materials as well. We also wanted to give people the ability to relax and pick out their own, take control of their own, the way that they chose to relax. And so making sure that we had different types of seating, giving a more feeling of hospitality. This is the front end of our hospital. We did some things like give unique things that would not be obvious. So when patients come into the hospital by ambulance, the ambulance entrance is in the back of the building, and we created all of our group spaces in the front so that when families came in, they didn't have to go across and pass other patients. Again, talking about personal choice and just giving people the chance to choose their own type of seating, have personal control over their environment. We activated the hallways a little bit so that they were not just, straight flat rooms that you would think of in terms of the old psychiatric style facilities. We also used color as wayfinding. And so that we wanted as a fundamental way for patients to be able to just, if they were under stress, they could find their room. They didn't have to necessarily look at the room numbers that they were in, and match the furniture on the inside to those colors so that they just really felt like they had a sense of ownership. So I'm happy to report that we were able to actually build this new space in the time that we needed to. We opened in October of 2022 and phased into our new place. But then we had to rapidly change our model. So on the weekend of February, it was actually February 5th, I remember, because I had a girls' night out scheduled, and my beeper went off, and there was an emergency in the hospital. We had sub-zero temperatures, and we had a pipe burst in our emergency room that was so bad it closed it down for 3 days. I happened to sit on the emergency management team in the incident command center, so I really was, in the heat of trying to coordinate getting everybody out of the ED, relocate all of our patients, et cetera, et cetera. On the last day, that was on a Saturday night, on Tuesday, we were just getting ready to close out the command center when we got another call. We had a fire at one of our hospitals in Brockton, as it coincidentally happens, at Signature Hospital. It was a 10-alarm fire, and it shut down the hospital completely. So we had to stay in our command center and figure out what we were going to do with all these patients, how we could lean in and help them do that. One of the things that we did in planning the new space was forward think. And while we built a clinical stabilization unit, which is more like a residential unit. In other words, it's not you're not locked in. It doesn't meet the requirements of a behavioral health design. It just doesn't need anti-ligature, it doesn't need any of those things. However, because we knew the demand was so high and we had the space vacant, we actually did build that into that system or into that unit. And that allowed us to more quickly than we ever imagined to open that CSS unit as an inpatient behavioral health unit instead. We ended up taking our very sad CSS staff and relocated them to another hospital. And actually it was another closed clinical care area that didn't need to have the behavioral health service criteria. So what we know is this: the lack of transitional services are pushing up readmission rates for all hospitals. Lengths of stay have increased as a result of not having a place to discharge patients. While we were thrilled to open this facility, we know it's not enough. We need to look at how we bridge the gaps in healthcare so that we have places to discharge patients to. Prioritizing the efficient use of square footage is paramount to reducing costs and reducing carbon emissions, and thus increasing overall inpatient capacity. We must do this today. Ask that you all think about ways to integrate behavioral health services, because it will be one of the ways that we drive down the total overall cost of healthcare. Thank you.
Q&As? Questions? We got one down here. All right, I'm coming.
Does your hospital just service adults, or is there a pediatric aspect of your behavioral health services?
There is a pediatric aspect. We treat all patients, geriatrics, primary care. We have ambulatory inpatient services. And when we talk about behavioral health, we actually did just relocate our pediatric services, and as part of that, relocated our pediatric psychiatry unit with them. Yeah, yep. No heckling, Doug.
What do you mean? You might have mentioned it. I'm sorry if I missed it. About 100 wells, I'm guessing, and
88 wells.
Yeah.
Dug 500 feet into the ground.
And then I did a similar project. It was a school building, but it was about $1 a square foot to operate. Do you know off the top of your mind?
I don't know the breakdown.
Yeah, it was stunning.
The overall project, we had originally planned for it to be a $20 million project, but with the help of the MHA money that we got, and we actually had a anonymous donor gave us $6 million to help us go over the finish line to net zero. It's a net zero energy building.
Yeah, and it's a closed loop system, right?
I think so, yeah.
And about just to help, maybe 2 football fields, 88 wells, about that big.
Probably, yeah. It's a zero fossil fuels. The only thing that we have is a gas powered generator, which is required for life safety.
Nancy, whatever happened to the behavioral health initiative you were doing when you found out about COVID?
Thank you. Yes, so we did go to Washington, as I mentioned. We did not present on the project. But we did come back and we met with the president of the hospital, who put us together to begin with to talk about that project itself. And what we talked about was integrating primary care into the behavioral health department. In October of this year, we will be opening our new psychiatric unit, and I am happy to report that it will actually have exam rooms meant for our primary care doctors to come and see these patients.
Excellent.
56 seconds.
6 seconds. Shout it out.
Yeah.
All right. Now, thank you so much, Nancy.